Well, first of all, it's a real pleasure to see you yet again and spend some time with you talking about some of the subjects that we love so much, which is perioperative management of neuromuscular blockade. So I'm joined by the world-famous Lars Eriksson, who's professor of anesthesia and academic chair at Karolinska Institute in Stockholm, Sweden. And I have to tell you, we've known each other for, 30 years or more. And it's always a real pleasure to see you and spend some time talking about the things that we really love. So, welcome.
Thank you very much, Soren. Likewise, it's been a pleasure for all these years. Over the years, we've done so much, and it's nice to sit here and reflect over the developments and the latest developments we have, truly.
Good. So, what do you think we should talk about today?
I think we shall focus on the fact that we now have received consensus documents from societies in anesthesia, the American Society of Anesthesiologists and the European Society for Anesthesia and Intensive Care, with guidelines for how to use neuromuscular monitoring in the operating room.
Yeah, so how do you think that that's going to impact clinical care? How important do you think that this, the publication of these guidelines is going to be?
This is truly a landmark event. I see it as a most important event when we now have uniform guidelines from the American Society of Anesthesiologists and from the European Society for Anesthesia and Intensive Care. And this sends a very strong signal to the world of anesthesia that we now need to implement neuromuscular monitoring as a routine part of everyday practice.
Yeah, I would agree with that, and it's actually quite nice to reflect back maybe 20, 25 years. I remember some of the editorials that both you and I have been writing for the last 20 years calling for guidelines and for implementation of quantitative monitoring in routine clinical care. And I think you're absolutely right. This is a watershed event. It's what we've been waiting for and hoping that would get implemented to benefit our patients. I mean, we've been doing this really for patient safety, nothing else. I mean, we truly believe that monitoring is better for our patients. So it's quite nice to be part of this and live long enough to see it actually come out in press.
And moreover, I think that this is also a step into personalized medicine.
Yeah.
We can now tailor the management of neuromuscular block for every patient and make very precise determinations of how to handle the block.
Correct.
Which is a very important step forward to provide the best possible care for the patient.
I agree. I would agree with that.
So when it comes to how to manage now the fact that we have these guidelines, what do you see as the next coming step?
Well, the next step is really probably the same thing that we've been hoping would happen for the past 20, 30 years, which is an understanding from clinicians that perioperative monitoring, quantitative, and I'm talking about quantitative monitoring. I think we do a lot of talking about monitoring in general, and looking at the patient or feeling the response to peripheral nerve stimulation is not really monitoring, that's just assessment. So it's time to actually introduce quantitative monitoring into clinical practice, and we have enough science to back this up. In fact, the science, all of the science says that quantitative perioperative monitoring not only leads to better outcome, patient outcome, but it lowers the cost, improves patient throughput, the hospital. I mean, there's not a single publication that I know of, maybe you can correct me, but there's not a single publication that has ever shown that quantitative monitoring leads to a worse outcome than not monitoring. So we have so much evidence in favor of monitoring and no evidence that it hurts. So to me, it doesn't make sense not to monitor quantitatively.
No, and the guidelines carefully and very precisely states that the quantitative method is the one that we should introduce now with those monitors that we can use in the OR. And I think that the next natural step now is for clinical leaders to provide neuromuscular monitoring devices for all the ORs where neuromuscular blocking agents are being used for patients. This is a step in itself. And then when it comes to the departmental level, it will take educational efforts. You and I and many of our colleagues working in this field of neuromuscular pharmacology and physiology have for several decades been involved in education, but now it comes to the department. And when it comes to the department, we must have local experts, local champions that can take over these both guideline initiatives and how they are, how they describe the introduction, what should be done. And also we need to spread these words locally, regionally, and
nationally, internationally.
Sure.
Correct.
And that's a very important step to get going now, because now we have done the literature search, the evidence is now here, and we have weighted these. They are graded in the documents, so everyone can see the level of evidence. And basically, we should come to a position where we, step by step now, introduce this for the best of the patient. Okay.
Yeah, I would agree with that.
You mentioned that we need to also emphasize on the patient safety side. I like that aspect. Put the patient in the center is very important. And we have a lot of evidence that we actually should avoid residual neuromuscular block.
Correct.
And both you and I have worked with educational efforts just to emphasize this. And we know that by using correct neuromuscular monitoring with quantitative methods, we can come close to zero.
Yeah. Well, yeah, that's true. So we can come close to zero. Actually, we should be at zero. If we look at the incidence of residual neuromuscular block, that by definition should be zero, because if we do not extubate the trachea until the train-of-four ratio is 0.9 or above, then by definition there's no residual block. So anything less than 0% incidence of residual block should not be tolerated. We shouldn't think that we did a great job if our patients continue to have some residual neuromuscular block. But that's important not just because we're treating numbers and we want to have zero incidence of residual block. The important thing is that we've shown for many years now that by avoiding residual neuromuscular block, we're decreasing the incidence of postoperative pulmonary complications. And that's where the outcome is. And for those who are interested in the monetary aspect of it, that's also where the money is. Because if we avoid postoperative pulmonary complications by doing away with residual neuromuscular block, we will lower the incidence of postoperative pulmonary complications by 40–50%. And that's been shown in the literature over and over again. So there really is no reason not to monitor.
No, and it's good that you emphasize on the important pattern of complications. So it's primarily the complications that are associated with residual block come more or less from the respiratory system.
Correct.
And it's also important to remember that respiratory complications is one of the most frequent categories of complications in the postoperative period worldwide. So since this is such an important factor for complications from the respiratory system, lowering the incidence of residual block close to zero is perhaps one of the most important things we can do.
We can do to affect, yeah.
Yeah. So, and that should of course also be a strong argument for clinical leaders and those that take the responsibilities for providing this new monitoring principle, quantitative monitoring and the OR, for the departments. So
correct.
It's important to stress that.
Yeah, and I think that it also becomes part of the individual clinician's responsibility once these monitors are made available. It is their responsibility to actually pick up, learn how to use them, and actually put them on patients and get the 0% incidence of residual neuromuscular block and lower the postoperative complications. So it's not just the availability, it's actually the willingness of the clinicians to embrace this new technology, like we've done with many other technologies. You know, I mean, fortunately or unfortunately, I'm old enough to remember when pulse oximetry was first introduced. And many of my professors at the time said, you know, I don't need a pulse oximeter to tell me that the patient needs oxygen. You know, I can just look at the conjunctiva or whatever. And here we are, you know, 30 years later, and we never even think of doing a case without a pulse oximeter. So, you know, over time, once the technology proves its worth, it becomes embraced and it becomes part of the routine practice. And that's exactly the same thing that should happen with quantitative monitoring. I mean, it should become practice, routine, part of the routine practice for every clinician.
So true. And we also have large regional differences across the globe. We have seen areas where, or countries where neuromuscular monitoring is not very frequently used at all.
And there are those where it is used very frequently, and
so
like Denmark.
Right. Scandinavia, I think, is
in general, correct,
is a region where we have introduced this. So I think there also need to be educational initiatives that are tailored to match the actual situation before implementation.
Absolutely.
To make this happen.
So another area that, you know, I think that we should probably cover is and it's very exciting that we actually have different technologies that are being introduced and have been introduced in the last decade or so that will make perioperative quantitative monitoring a lot easier. So, you know, I think most people are pretty well aware of the acceleromyography and, you know, the ubiquitous TOF watch, which, you know, many people have used, and we've done a lot of, most of the studies that were done in the last 20 years used acceleromyography and the TOF watch. But, you know, so that's a very good technology that depends on movement. So it has to measure the acceleration of the moving thumb. And that's been used for, as I said, for 20-some years. It has very good penetration. It's relatively easy to use. The problem with acceleromyography is that it needs to be both calibrated so that to make sure that you're starting out with a train of 4 ratio of 100% and that doesn't change over time. But more importantly, there's this peculiar property of acceleromyography where the train of 4 ratio, which should be 100%, right? Is actually not. It's usually higher than 110%, sometimes as high as 140%. So if you're starting out with a baseline of 140%, you know, then what we should do is at the end of the operation for extubation criteria, we should be looking at 90% of 140% as the threshold for extubation, not 90% out of 100%. So this step, which is comparison to the baseline, is called normalization, and I think it's very important to take place. And we've seen, for instance, in some of the recent studies, like in the popular study, because acceleromeography was used and the results were not normalized, actually the results were not that good for a 3-to-4 ratio of non-normalized 3-to-4 ratio of 0.9. And yet when you started looking at ratios above 0.9, like 0.95, all of a sudden we saw that it is protective. So this normalization is very important. There are other technologies like electromyography, which doesn't need to be. It starts at 100%, the 3-to-4 ratio, and over time it stays at 100%. So it doesn't have this inverse fade where the ratio goes above 100%. So that's a real advantage. It also doesn't need to be, so it doesn't need to be normalized. It also doesn't need to be, the baseline is pretty stable. And perhaps most importantly, for surgeries where the arms are not available to the clinician. So the arms are sometimes tucked to the side, like in laparoscopic and robotic surgery and or prone position. A lot of these surgical procedures where the clinician just doesn't have access to a moving extremity. In those cases, acceleromeography is not going to work because it interferes with movement of the thumb. Electromyography can be used in those areas. So every technology, you know, I can't say that one is better than the other. I think it's up to the clinician to actually use the technology, figure out what works for him or herself in their own practice, and then adopt it. It doesn't matter which one they adopt. They have to know the strengths and limitation of the particular technology, and then use it. I mean, that's basically it. Learn it and use it.
I can't agree more, Søren. I think also that many of the failures that we see in everyday practice are a result of how to position the hand, how to mount the electrodes and the devices. So as we come with more advanced, more user-friendly devices, where we take action to limit the possibility of single failures due to that the setup procedure is done in an incorrect way, the electrodes were placed in an incorrect position. As much as we can do to reduce that for the clinicians, that will help us to work with these monitors in the OR.
Yeah.
And I think we come that way. I think that the general awareness of that the human failure thing is maybe the most important factor behind when monitoring is difficult on a regular day.
Yeah. No, I'm glad that you mentioned that, because one of the, I don't want to say excuses, but one of the frequent complaints that I hear from clinicians is that, you know, I just don't have time to monitor, you know. And I don't quite understand the concept, because, I mean, there are studies that have timed how long it takes to put on a peripheral nerve stimulator or an acceleromeograph or an electromyograph, and they all take about the same, and it's less than a minute. I mean, if we cannot take a minute of our time, or actually it's the patient's time, for their safety, then I think that we're doing something wrong. So, you know, the new monitors really are quite easy to use, and they're easy to put on. You know, the electrode should go on the nerve. I think most of us have gone through medical school, so we should know where that is. And once the electrodes are placed appropriately, monitoring should be relatively simple and certainly not time consuming.
And moreover, I think one other aspect, you mentioned it also, is that the only way of actually pioneering and be a really good at using this on an everyday basis, that is to do it over and over again.
Yeah, yeah.
That's the way that we trained, and how you and I think have
Yeah.
adopted this technique as a natural component when we
Incorporate it into our own practice.
right,
Absolutely.
and do it over and over again, just to learn and make it happen.
Yeah, but I think that to some extent, maybe that's also one of the problems, right? Because we get very used to doing things our own way. And let's say that, you know, I've been practicing anesthesia now for, pick a number, 20 years. And I've always used a peripheral nerve stimulator. Or I've always looked at the patient and, you know, decided whether the clinical signs were adequate for extubation and so forth. If that has become part of my practice, it's somewhat difficult now after 20 years to say, you know what, I'm not going to look at the ventilator bag and see it move. I'm going to use, you know, a quantitative monitor. And I understand that. But I think that there's, you know, we all have to understand that these changes that we're proposing, they're actually for the patient's benefit, and it'll make the practice, individual practice better, and it will improve patient safety. So it's, you know, we don't want to change people's practice just because we want to change practice. We want to change it for the patient's benefit. And that's the big motivator behind changing one's practice, I think.
True. And I also think, Søren, that the young generation will adopt these methods more quickly than
I would agree with that.
Our
Absolutely.
generation.
I would agree with that.
Truly. So
yeah.
Hopefully the barriers we will overcome the barriers, and we should of course do everything we can to assist every department in how to make this happen.
I agree with you. I think that we need to train the next generation to use appropriate monitoring. Absolutely. Okay, so at the end of this, thank you very much. It's been an honor and a pleasure spending a few minutes with you talking about the subject that we both love so much. I think it's really imperative that we teach the new generation about perioperative, the reason to be incorporating perioperative neuromuscular monitoring into routine clinical practice. And I'm sure that you have a couple of things to say as well.
Yes, Søren, I thank you very much for inviting me here.
You're welcome.
To give comments on this. It's a most important thing we have in front of us now, to set the incidence of residual paralysis to zero.
I would agree with that. Let's strive for 0% residual neuromuscular block.
And thank you so much for inviting me here today.
Thank you.
Thank you.